My name is Simone Pobega, and I see my teammates here, Shannon Hunter and Annette Roberts. And we are the registered nurses with the Regional Center for Suspected Child Abuse and Neglect and the Regional Sexual Assault and Domestic Violence Treatment Center. We are 3 full-time RNs, and we also cover the program on call 24 hours a day, 7 days a week, 365 days of the year. So I'm going to share my screen and we'll get our PowerPoint presentation on the go. But as we are a smaller group, I am open to people interrupting and asking questions as we go along so that opportunities aren't missed, and that you know, I can know what you guys are looking for and what is relevant to what you would like to learn about today. So I would like to start with the OSMH Land Acknowledgement Statement. Orillia Soldiers Memorial Hospital acknowledges that we are situated on the traditional territory of the Anishinaabe Nation. We would like to acknowledge the enduring presence of the First Nations, Métis, and Inuit peoples of this region, specifically the Tri-Council First Nations, comprised of Beausoleil First Nation, the Chippewas of Rama, and the Chippewas of Georgina Island. We also acknowledge the Moose Deer Point First Nation, the Watah Mohawks, the Georgian Bay and Moon River Métis councils in this region. It should be noted that the Wendat and the Haudenosaunee nations have also walked on this territory over time. Disclosures: we have no affiliations, or sorry, no relationships with for-profit or not-for-profit organizations. And this session program has not received financial or in-kind support. And so there we have our title, which as Kathy had noted earlier, is quite the mouthful. We are the Regional Sexual Assault and Domestic Violence Treatment Center and the Regional Center for Suspected Child Abuse and Neglect. It's the same nurses covering both programs. However, with the pediatric portion, which is, we call it for short RC scan portion, we do have access to 8 pediatricians as well as 2 currently part-time social workers that make up 1 full-time position, providing therapy for children who have been sexually abused or physically abused. So who we are, I kind of went through that already. 3 full-time registered nurses, 2 part-time social workers, and then 8 pediatricians. We are regional, so we cover Simcoe County and Muskoka. So probably Parry Sound is the furthest north that our demographic reaches. Furthest south is probably about Bradford and Innisfil. And then the next center to the east of us is Peterborough. The next center to the west of us is Owen Sound or Orangeville. And I think north of us would be Sudbury and North Bay. They both have treatment centers that would offer similar services to what we have, but again, some of them vary. So there are 37 centers across Ontario. We all run under the network of sexual assault and domestic violence treatment centers. But again, what each center offer may vary as to what the needs of the community are. We started the Sexual Assault Treatment Center in 1993. In 1998, we began to see domestic violence clients as well. In 2002, we began seeing the pediatric sexual abuse clients. And then in 2005, we more formally started seeing the pediatric clients for both physical abuse and neglect, as well as sexual abuse, under the heading of Regional Center for Suspected Child Abuse and Neglect. So I think our center, that means our center's been around 27 years now. I remember we celebrated our 25th, but it's 27 or almost 28 now. So we've been around for quite a while. So as far as our clientele goes, for us to be involved, the client must consent to our services. If they refuse to see us, we will not be seeing them. If they're undecided, that's a lot different. Then we can talk to them about what we can offer, how we can be involved. They may consent to some pieces of our care, but not all pieces. They may consent to receiving medications, but not doing the kit, or vice versa. They may consent initially for us to be involved, but then change their minds, and that's fine. So we go through that with them. We tell them that all up front, and it usually makes them a little bit more open to receiving our services and speaking with us when they know that everything's entirely up to them. And if at any time they want to stop the process, they can. We see both men and women who have been sexually assaulted, and both men and women who have been physically assaulted in an interpersonal relationship. So that's the domestic violence aspect of it. And then we see children who have been physically or sexually abused as well. And we will get into that a bit more, how we break that down. But the next few slides are just show where our clients are from. So you'll see Parry Sound, yeah, is the dark one at the end there. So not a lot from Parry Sound. Most of our clients come from the Barrie or Orillia area, which makes sense because they're a little bit closer and more populated. But we do regularly get clients from Parry Sound, generally referred directly from OPP or the West Parry Sound Health Center, like direct referrals from them, as opposed to people finding their way to us on their own. And then this is 2019 to 2020, and I believe there's one more. It's 2020 to 2021. So it remains pretty stable as far as where the clients come from that we are seeing. So a few reasons that clients may not want to involve police. And again, these are changing as societal perceptions are shifting as well. But a lot of times they believe that police might not be able to do anything about it. They don't want to face the judgment of either police or the court system, because they may feel, well, it says fear and shame as well. They may feel shame for what happened, or they may feel that they're to blame for what happened, and that either the courts or the police would blame them. Or they fear repercussions from the offender, that if they report the offender, if police or courts aren't able to do anything, that offender will still be out there in society and able to harm them in some way. So we can see sexual assault clients 12 years of age or older. We can do a sexual assault evidence kit with them within 12 days of the assault, which a lot of people are really surprised at that. Best evidence collection would be within 72 hours. Obviously, the sooner we do the evidence collection, the better chance that there will be evidence there for us to collect, but we would complete a sexual assault evidence kit up to 12 days after the assault. Generally, for domestic violence, if the assault occurred within the past 4 days, is the best time to see them. We have seen them outside that if injuries are still visible. So that can be a bit of a gray area some days, but sometimes. But best photography and injury documentation would occur within that 4 days of the assault. And also, does the client consent, and can they provide informed consent? So, don't transport them to our hospital if they're unconscious, if they're not able to consent, if they're in a state of psychosis, if they are incapacitated by alcohol or drugs. We need to wait for those things to clear, and generally we do have some time before they're transported to us for us to complete the sexual assault evidence kit. If they can't provide informed consent and we collect the kit anyways, then all of that evidence and those results would be thrown out in court because there wasn't proper consent provided before that evidence collection occurred. Emergency medical treatment always takes priority over evidence collection. So if somebody presents to West Parry Sound Emerge, they need to be medically cleared before they're transported to us. So any pain, injuries, or mental health issues need to be dealt with prior to the client coming to see us. And then, does the client agree to be referred to us? And sometimes if they don't want to see us right away, sometimes they may agree to speak to us over the phone, maybe not in the middle of the night, but they may agree to a phone call the next day so that we can discuss further options with them if they don't want to involve police. If they're adamant that they don't want to do a sexual assault evidence kit, do they want to do medications? Can those medications be provided in West Parry Sound Emerge? Or do they just want resources for counseling so that they can make the phone call when they're ready to get some counseling and complete their journey that way, as opposed to going through police and the court and justice system? So the referral process, always, we can't stress this enough, always give us a call. We are on call 24 hours a day, so we're always going to answer that phone. You can always get a hold of us. So before, even if it seems cut and dry, before sending them down, just give us that heads up. First reason, if they're coming down from West Parry Sound, that gives us a chance to get up, get dressed, get ready if it's in the middle of the night, and meet them here at Emerge, as opposed to our Emerge calling and letting us know someone's arrived to see us, and then that client has to wait up to 45 minutes while we're getting our act together and getting into the hospital. If we get that heads up that they're on their way, we can be at the hospital, we can have the room set up and ready to go. And then we want to know, if they're coming from West Parry Sound, is the transportation that's bringing them, is it also bringing them back, or do we need to plan for that? Are police involved? Can they provide informed consent? Have they been medically cleared? We'd want to know all those things. And then what has also happened is that we can talk directly to the client over the phone, because if they're undecided about whether they want to come see us or not, sometimes it's just that kind of reassurance that, whatever we do, it's entirely your choice. These are the things we can offer you, or what are you concerned about that I haven't talked about? Can I help you in that way? So sometimes it's very reassuring for them to be able to talk to us over the phone and just say, well, this is why I don't want to do this. Because if it's because it's been 3 days and I don't think there's going to be any evidence there, well, you know what, I can do it up to evidence collection up to 12 days later. So, if it's within 72 hours, that's actually really good. So come on down and we'll get you taken care of. So we can also talk directly to the clients over the phone as well, while they're still in West Parry Sound Emerge. So sexual assault treatment options, sexual assault evidence kit is probably the biggest thing that clients are referred to us for. That has about 12 steps in it, but it depends on, we do 4 pages of questions. I call them yes, no, or I don't know questions. So what happened during the assault? Did this happen? Yes. Did this happen? No. Or if the client doesn't remember anything, she would just answer all the questions with I don't know. And that's okay too, because then we just go ahead and assume that we can collect that evidence if the client consents to that. So it's not a short process. It can take up to 4 hours. Usually I would say we can complete the process in 2. But if there are injuries to be documented and photographed, that will make it take longer. If the client's having a difficult time, we move a lot more slowly. That can take longer. So there are things that can make it stretch out a little bit. But that's okay, because when they're here, they're our only person we have to see. We're not emerge nurses that are pulled to, 5 different clients all at the same time. That client is our #1 priority, and that's what we're there for, is to help get them through this. We can offer medications for the prevention of chlamydia and gonorrhea, as well as, if they consent, we can initiate a 28-day course of HIV prevention medication, and that cost is covered through our hospital. Physical exam and treatment of injuries, as well as injury documentation and photography, pregnancy testing and prevention, forensic evidence collection with or without police involvement. So again, if police aren't involved, if the client says, I don't want to involve police, we can offer them that option to say, well, maybe you might change your mind, and we can do the evidence collection. We would hold it and store it for up to 1 year while you decide, whether or not you want to involve police. Sometimes the client is adamant that, like, no, I will never, ever, ever want to involve police, and that's their choice. But sometimes that makes them, kind of say, well, maybe someday I might like to. And then, it's the 2 to 4 hours that we spend now doing the evidence collection will help keep your options open. So sometimes they will decide to go that way. There's 2 separate consents that they sign when we do a sexual assault evidence kit. The first is for us to be able to collect the evidence from them. The second one is for us to be able to release that evidence to police. So they can always sign the first one and not sign the second one. And I believe that can help them make feel a little bit more in control of the process and of what's happening, and that, they're more in charge and able to make decisions that are right for them. Support and crisis intervention is mostly just us saying, this isn't your fault, you have options. There are people that will help you through this, as well as referrals to community agencies for either counseling or for whatever they need. If they have nowhere to stay, trying to get them set up with a shelter, talking to them about what police involvement might look like. Just if they need anything through victim services, helping get set up their residence to be more safer, replacing locks or getting sensor lights put outside, then those are referrals that we can help them make. And just make them feel like they're not going through this on their own. There are people that are going to help them through this. And then we would do follow-up visits with them as well, and follow-up phone calls. So on follow-up visits, it may be for the HIV prevention medication, continuing on with that with them. After 6 weeks, we can do STI and HIV testing. And just phone calls as well to make sure that they're hooked up with the community supports that they need to be hooked up with. And if not, well, why is that, and how can we help facilitate that? And I think I'm gonna hand it over to my colleague Annette for domestic assault treatment options.
Excellent. So good. All of the consent pieces, sorry,
just bear with us one moment.
Oh, you probably could have minimized, but yep, there we go. So all of the consent pieces are the same for the domestic assault side. They can choose to come and see us and can choose which pieces of our program they would like to have in the moment or even days later. So some of the treatment options would include injury documentation and photography. So it can be a long process as we're assessing pain and the size of the injuries, as well as doing multiple photographs for court purposes and making sure we get really good photos. We would also do a risk assessment, making sure that they are healthy and safe enough mentally and physically to go home or to a safe place for the next foreseeable future. And safety planning. If the client is choosing to go back to the relationship and the environment that resulted in this injury, then we talk about how they can keep themselves as safe as possible when returning there. So that could be things like making sure you have an extra set of car keys, making sure you have a small stash of money that's hidden somewhere, that you have a support person that is aware of what's going on and able to help if you need in the moment. We would also do referrals to a safe place. That could be currently with COVID, unfortunately, it's changed a little bit, but Greenhaven here in Aurelia, there are services that are available even with COVID where we are having beds in hotels for short-term stays. We would look at referrals to community agencies for support and counseling. If there are children within the home during these events, that could involve Family Connections or Children's Aid Society for the safety of those children, as well as counseling processes. And like Simone said, it could include victim services, changing locks, increasing the safety of the home, or even helping get a replacement cell phone if that's a need. We would then talk about a mental health assessment and perhaps refer them back to our emergency department to help facilitate that with the emergency physician and maybe even our crisis nurses who are here not 24/7, but often and can do some follow-up stuff with the clients. We then do a follow-up visit, either on the telephone or a second in-person visit if there are more photos that could be taken. Not all bruises and injuries come out in the moment, and they may take a couple days to show. So we can do a series of photos that would show those injuries progressing. I think you need to move it. Yeah, fabulous. So we're going to move on to, oh, this is a sexual assault one. That's okay. So case study number 1, an 18-year-old female presents to your emergency department and states that she was sexually assaulted at a hotel about 2.5 hours ago by 2 unknown males. There was alcohol involved. She is scared and alone and worried about some injuries. So the question is, what would you do? Anybody want to jump off mute and give some ideas?
I think we have to start with medical clearance, right? Especially if alcohol is involved, but maybe.
Sorry, Heather, we can't hear you. You jumped off mute, but you're quiet.
Can you hear me now?
Oh. Yeah. You're jumping? Or I can jump. It's actually us, Heather. Just one second. Okay.
Okay, so I think we have to start with medical clearance, right? Because there's alcohol involved, but then we could probably initiate the phone call for support from you just to make sure that you're aware of this client and that we could arrange maybe follow up if, they're going to sleep overnight and, we're going to give fluids kind of thing. Would that be?
Yeah, absolutely. As long as she is in your emergency department, she's safe, right? So we can start that conversation as soon as she is medically cleared. And that would decrease the time frame, right? If we're both involved at the same time, could minimize the length that she stays in the emergency department, but also be the time frame for treatment with us as well. So that's good. Can you flip? Fabulous. So the emergency physician or the nurse could contact us on call. Like Simone said, we are available 24/7 and chat with the client to see if she wants to come down to see us and consents to see us. So like Heather said, she would need she needs medical clearance at, this is a different copy. That's okay. At your emergency department first because of her potential injuries. And then can she be transported to Aurelia safely? And if she can, fabulous. What's her route back if that's a concern still? And depending on the COVID chunk of our world, does she have a support person that she would like to have come down with her? This isn't a short process, and it's nice to have a friendly face and a supportive individual with you. They do not have to be involved in the actual process. We have a waiting room that's close, that they can be there and just know that they've got somebody that is looking out for their best interest on the other side of the door and is their potential safe ride home in the next couple hours.
Do these assessments physically take place in the ER, or do you have like a special like unit or area for?
Yeah, we have a treatment room that's just outside of the emergency department. So the emergency physicians, when we need them, they have the ability just to slide through a hallway and come and help us with either medications that the client's taking that may interfere with the medications I want to give. If there are physical injuries, if they presented just to our emergency department, say it's a physical injury to the genitalia, then when we're doing our assessment, they could come over and help in the same moment rather than doing two separate assessments, just to minimize the time and the potential for evidence collection may be lost if an emergency physician does an assessment first and then we see them. So it just streamlines it. It's nice and close though still. So if there's any concerns with mental health or physical health, we have emerge and nursing staff nice and close. Yeah.
Oh, thank you. And I have one more question. It's kind of
Absolutely.
like, it's a little different. It's more like a scope of practice question because I'm very interested. It's very intriguing what you do. Is it like medical directive based, like these programs and these algorithms that you work through? And then it's like physician supported, obviously, and whatnot.
Exactly. We have a medical director who has helped us develop a medical directive that covers us. Currently, it's an acute medical directive. So it covers us up until that 12-day mark, which allows us to do all the screening. So depending on the timeline, we can do all of the STI testing, as well as pregnancy, HIV, Hep B, all of those, as well as giving preventative medications for gonorrhea and chlamydia on the medical directive, initiating HIV medications are on the medical directive, Plan B as well. And currently our practice is we test immune status for this clientele, and then we would connect with them. If they don't have good immunity, then we would like to see them so that we could give them HBIG and start their vaccine series. If they have good immunity, then we let them know that they do, which is good in this scenario. What else is on there?
It's really neat. It's like really great wraparound care that you're providing too with the immunity. That's really awesome.
Yeah, that's a new one for us. But yeah, it's all wholesome. And then we try to, if they don't have the means to come back and see us for some of that follow-up testing, including the Hep B, we connect with their family physician if they need some of that extra support to get that process done for them if it's closer to home or less drive. Right.
Okay, thank you.
Mm-hmm. I don't know what comes next. I can't remember. Sure. Okay. Okay.
All right.
You're good.
Just wait for the little mute to come up. Okay. So I will take over case study number 2. So police and ambulance have brought in a 46-year-old female. They were called during a physical altercation with her current partner, resulting in the client falling downstairs and injuring her shoulder and her head. Physical assessment determines her shoulder is dislocated. Her left forehead has edema and bruising, as well as bruises on arms and legs. And what would be your first steps? Does anyone want to volunteer?
Hey, Jordan here. Can you hear me? Yep. So first step would just be to assess her to emerge, obviously, get her shoulder fixed and treat her pain.
Sorry,
And
just
then-
bear with us one moment.
We're sharing an office, so we can't have both of them at the same time.
Gotcha. Ready? Yeah, so you'd want to treat her pain, fix her shoulder, obviously, and then determine if she wanted to talk to you guys, I guess. And we would initiate a call. And for this situation, it sounds like something that might be able to be done over the phone, possibly. So yeah, I would call you guys and treat her pain.
Absolutely. We could definitely talk to her over the phone, because also this is in the middle of the night, and she has bruises that can be, she may want documentation done for. Then we can always see her within the next day or two, because often if police are involved as well, there's a lot going on. They're going to have to, if they can't stay where they are, then they have to find other arrangements for living, whether that be a shelter or family members. They're probably in a lot of pain. Police will want to take statements from them. So with the injuries, again, within like that 72-hour time frame is best. But sometimes it may take 24 hours for the bruising to be fully appreciated, to fully come out and be visualized. So it's not always necessary that if it's the middle of the night or that same day, they come see us right away, but we can talk to them over the phone and decide what works best for them. But yes, you're absolutely right. Pain and physical injuries, medically cleared, and then determine if she consents to see us, and then arrange transportation from there or make a follow-up plan for her. Thank you. Oh, we have a question.
Hi, my name's Kara. A question I have, if they have a dislocated shoulder, so we've obviously done some images at our facility. I'm just wondering, at what point would we share some of like our disc or something to be part of the case if she decided to press charges? Because we'd have that shoulder back in place before you saw her. So what would you need from us, from the Emerge department?
So when the police do become involved, then our evidence collection kit is one consenting process. The remainder of her health record would be a second consenting process, where the police would actually connect with your health records department and ask for that chunk of record to add to their summary of what has taken place. So we only release in our program our pieces, but if they have spent some time in the emergency department, that would be additional health record paperwork that would be released. So it would be the same for your facility. Would just all add to that larger picture of what took place.
Perfect, thank you.
And just to bounce off that again, sometimes Emerge physicians will be proactive, and they'll provide her with the antibiotics for chlamydia and gonorrhea, as well as Plan B, prior to us coming to see them, or sorry, them coming to see us. And so if there has been any medical care provided by Emerge, we would ask that your Emerge would fax that health record to our Emerge, so that we could access that information when it's our turn to see the client. That can be helpful if you are working in Emerge, just so you're aware that that would be good for us. So let's see what we have here. Medical treatment is main priority. Under conscious sedation, left shoulder is now in place and in a sling. Then contact our SADVRN. Then we can develop a plan to complete documentation. So I think these are based off of real cases. So this is just what occurred in that case. including injury documentation and photography. In this particular case, her daughter was a good support for her and gave her a safe ride home, and police had arrested the assailant. Okay, so we have our pediatric case study. So when the child is 11 years old or under, they're seen with both the nurse and the pediatrician. So things we would want to know is, has the child disclosed abuse? So if they're, 3 or 4 years old and under, are they verbal? If they have not disclosed abuse, why are we concerned about abuse? What has occurred that has made us concerned that either sexual abuse or physical abuse may have occurred? And if we believe that abuse has occurred, is that within the previous 72 hours? So if it has been within the previous 72 hours, they could potentially still have evidence collection completed, and then that would be an acute visit. But frequently with children, those disclosures happen outside of that 72-hour time frame, sometimes weeks or months later. And then we would refer them to one of our clinic visits. We run clinics usually about every 2 weeks with the pediatrician and a social worker present along with the nurse. And that is basically a well child exam. So the pediatrician would do a head to toe physical exam, look in their ears, look in their eyes, listen to their bellies, but the genitalia is part of that exam as well. And at that point too, we call it a well child exam because we're not expecting to find anything. It's more for reassurance for the child and the family that, this may have happened, but medically and physically, everything is okay. We can also do, depending on what the disclosure was or what the concerns are, we can do STI testing at these visits as well. When the abuse or assault happens to anyone under the age of 16 years old, we do have to call Family Connections. So if West Parry Sound Emerge is that initial contact point, and if there are concerns that a child has been abused, we would expect West Parry Sound to complete that initial phone call to Family Connections and get the ball rolling on that. So that they can do their piece, because that child may need to be interviewed prior to us seeing them to determine as best as we can what actually happened to the child, because that will guide our treatment and what we will be doing. Again, you can contact the registered nurse through switchboard the same way you would with the sexual assault or domestic violence clients, or the physician can call directly through to the pediatrician on call and discuss their concerns with them, because it would be the pediatrician on call that would basically lead the visit and determine what we would be doing, working with the RN on call. So the same with physical abuse. Have they disclosed? Otherwise, what are our concerns? If they have injuries, we like to know what's the stated history of those injuries, what are parents saying has happened, and then do those injuries need treatment? Was the abuse within the previous 72 hours? And are police and Family Connections involved? And then getting a hold of the, usually the pediatrician on call through the switchboard to determine how we can be involved and how we can best support the family. So again, it can be either an acute visit through our Emerge or a clinic visit. That's booked usually every 2 weeks. So again, it's a head-to-toe physical exam by the pediatrician. For an urgent visit, we could potentially do a sexual assault evidence kit. For physical abuse, generally, depending on the age of the child and what occurred, there may be some x-rays or CT involved, blood work to rule out any bleeding disorders, And then if it's a sexual abuse case, we can do STI prophylaxis or testing, depending on when the assault occurred, photo documentation of injuries, and a referral to our social worker. So just on that piece about the counseling, our social workers become involved when the abuse has been verified by either CAS or police. So charges don't need to be laid, but CAS or police do need to say, yes, we believe this has actually happened. We just don't have enough evidence to go forward through the court process. Because our social workers provide, they call it therapy as opposed to forensic support. So they need to determine that, yes, this has already happened, so that they can provide therapy and healing for that child. And then case study number 3. Sorry, just wait 1 minute. So case study number 3, a 6-year-old female is brought into emergency department by their mother for concerns of possible fondling and penetration that may have occurred 2 weeks ago. Mom is extremely upset. And I'm just going to minimize my computer screen here and turn on my sound. Before I ask for anyone to participate. Okay. Okay, sorry about that. And does anyone have any thoughts on that? Sorry, I see someone's, oh no. Any thoughts on where they might start with that?
I think we start by calling you, maybe, especially if this is from Perry Sound. Like obviously we're conducting a physical assessment and clearance and then calling for support.
Yes.
So that you can perform the well child and follow up with them appropriately.
Absolutely. So if I got this phone call, I'd probably direct the physician to speak directly with the pediatrician, just to make sure, that they do a full assessment, that the child doesn't have any injuries that may have occurred during the abuse. I'd want to make sure that CAS is involved, because at this point, we want to make sure that child has a proper forensic interview. And then that would be led by Family Connections and police working together. And then we would see the child after that forensic interview is complete, so that we know what any further concerns are. We'd want to make sure that mom doesn't question the child too much about it, because we need to wait for that forensic interview to happen, so that mom doesn't contaminate any of the questioning that Family Connections and police may want to do. Okay. So obtain and clarify history. Generally, you want to do that with mom in a room separate from the child, just so that it doesn't contaminate anything that the child may need to say. And then talk directly with us about how we may plan best to support this child from here on in. Generally, that would be through contacting Family Connections and police. And then we would connect with mom the next day and plan to see her in our next pediatric clinic. So again, with the children's aid, there is a duty to report for anybody 15 years of age and under. These are some of the quality assurance measures that we have in place. We peer review cases amongst ourselves with our 8 pediatricians, but also with the Sick Kids Scan team, under whose guidelines we run as far as the RC Scan program is concerned. And we also attend the annual Sick Kids Hospital maltreatment conference for any updates, any new things coming out, lots of good case studies with the maltreatment conference, just to make sure that we're all on the same page with everyone else who is in this line of work. Quality measure assurance for our adolescents and adults. We again run under the guidelines for the network. We regularly update our medical directives. And we do case studies and attend the conferences provided through the network as well. As well as this year, we did attend virtually, because it's now virtual. The International Association of Forensic Nurses holds a conference usually in the States. This year it was in Orlando, but we were able to attend all the sessions virtually, which was really great for us, because this work can be very isolating, and there are 3 of us, but it's us bouncing ideas off each other or other people within our Ontario network. So it was nice to see what the international community of nurses, forensic nurses, does as well. So it was really, really good. And I'm just going to see what we have here. There we go. It's question and answer time. So I think I may stop sharing my screen, because I can see things better when it's not taking up, there we go, taking up my whole screen. And I just wonder if there's anything I didn't address that people had questions about. Yes, Jordan.
Just because we don't typically hear what happens after, like, how long does the interview with you guys take typically in the emergency department? Is that like a couple hour thing, or?
Yeah, so for us to see somebody, it can vary pretty widely depending on their needs. We don't interview the children ourselves. Interviews are done through Family Connections and police. Generally, we like to have them completed at our local Child and Youth Advocacy Center that has a building in Aurelia, as well as a building in Barrie, that they can complete interviews out of. However, for us to see somebody from initially seeing them and emerge through the whole visit can take up to about 2 to 4 hours, depending on what they choose. If they choose a sexual assault evidence kit, if they choose injury documentation and photography, depending on how many injuries they have, if they choose medications, all these things add a little bit more time onto their visit. And it can get really long if they need to be medically cleared for something, because then we're usually helping to facilitate that process through our emerge. Does that answer your question? Is that what were you asking about? How long does it take to interview through Family Connections and police, or complete the process through our end through what we do?
Yeah, that mostly answered it. Yeah, I was just like curious for adults too, you know, like
Right.
yeah, for just sexual assault,
Right.
they come down and they want to get, you know, pictures taken and all the tests done. Yeah.
Yeah, it can take, usually I would say, between 2 to 4 hours. It's not a quick process, and it can be pretty tedious for the clients, because it's a lot of us writing down times. Like, we collect a sample and then we spend 5 minutes documenting about that sample. So it can be pretty tedious for them. But usually we can get done what we need to get done in about 2 to 4 hours, depending on what they need. As far as, sorry, only because you had said interview before, it made me think of interviewing the children. Generally, like, if it is to be an emergent visit that needs to be completed with the child, we prefer Family Connections and police to have interviewed the child first prior to us seeing them, but sometimes we know that's not possible, so we will try and work that out with police and Family Connections if they can't get that interview completed before that 72-hour mark, where our time may run out for forensic evidence collection. So That's just also something else interesting to note.
That's good. Thank you.
Yeah, no problem. No problem.
Simone, it's Heather.
Yeah.
A very subjective question. Have you noticed an increase in pediatric cases throughout COVID or cases in general?
Kathy and I were talking about that before we started the presentation, so I'm glad you brought that up, because I told Kathy, you ask those questions at the end because that's important information. What we were talking about as far as increases go, domestic violence, we did see a bit of an increase for us, probably from about maybe 1 to 2 to no clients per month, going up to about 4 or 5 clients a month. So that was a pretty big increase for us. And I want to say, I don't remember exactly when it occurred, but it occurred over several months. I want to say maybe at the beginning of 2021. I don't know, Annette or Shannon, correct me if your memory is better. But there was also a big increase for quite a while, probably over like 6 to 8 months of pediatric physical abuse cases as well. So we were seeing a lot more kiddos urgently through eMERGE for injury documentation and exams with the pediatricians. As far as sexual abuse has gone on the pediatric side, I know our pediatric social workers next door have seen a big increase in sibling to sibling sexual abuse. I was expecting, I personally, subjectively, was expecting a lot more disclosures to come out once kiddos went back to school. And there was a safe adult to disclose to once they're out of the home. I didn't necessarily see that. We did see our clinic visits did increase since September, but not particularly because they're out of the home and able to disclose to a teacher, which is what I would have expected to see more of. I didn't see that. So, but good question. Thank you. Thank you. And I did forward to Kathy, and I believe she's forwarded to you guys, is very handy. We call it our physician letter. It has a chart on it and just kind of breaks down our 3 different areas of our program. So the adolescent and adult sexual assault, adolescent and adult domestic violence, as well as our Regional Center for Suspected Child Abuse and Neglect. Just the different referral criterias and what options are available to clients. So that's also, if you print that out or if you save it as a PDF somewhere, it's also really handy to have when somebody comes through eMERGE, just to see what we actually could offer, depending on the time frame of when the client presents. Anything that I didn't cover that people are maybe interested in knowing more about?
I'm wondering about presentation. When you potentially see it, but they're not voicing it.
That can be really difficult. That can be really difficult. So that makes me think of kind of 2 separate things. Is when a parent is calling us because their child's behavior has changed, but we can't, there's no screening for determining whether or not a child has been sexually assaulted or not. You would think that there would be, because a lot of people are mistaken about the physiology and anatomy of the vaginal area that the hymen is actually covering, that goes over the opening of a vagina, but it's actually a band of tissue that goes around the opening of a vagina. So we can't necessarily tell whether or not anything has happened to that area, particularly with kiddos. They're so resilient and so quick healing. Maybe something that was there a week ago or even 2 days ago, an injury that may have occurred, it has healed and it hasn't left any what they refer to as residual effect. There's no evidence to show that that injury was there just because of the nature of that area. So that we have to tell parents, like, we can't tell you, we can't answer that conclusively for you. It does need to go through Family Connections or Child Protection Services for them to be able to conduct their forensic interview. So we don't do exams for that reason, to rule out sexual abuse if CAS and police are not involved. The other thing that makes me think of is when we're concerned about human trafficking or violent relationships, where this person may have presented to emerge before, and everybody thinks that there's more to the story. This person's very closed down. They're not answering questions directly. They're not giving, there's a lot more information here than we're not getting, like the story's just not adding up. So at that point, like, we really rely on our emerge nurses to say, you know what, you can talk to somebody if you want to. They won't call police. Again, if they're 15 or under, we have a duty to report to Family Connections. However, if they're 16 or over, we don't report to police. So, you know, you can get these injuries documented, you can share information with them. It will be in your health record, but it won't be released to police unless you want it to. So sometimes that helps people at least even meet with us, let us go over options with them, and whether they choose to share more information from there, it's entirely up to them. Sometimes they do, sometimes they decline our services. So, but that's a very good question as well. Thank you.
Simone, I have another question.
Yeah, absolutely. Good. This is great.
When I'm calling CAS, should I be calling Family Connections as well, in addition to?
So Family Connections in our area, and I think it's the same as Perry Sound, it is CAS.
Okay.
It's the same. Yeah. Sorry, I use them interchangeably because they used to be CAS. They're now Family Connections, but Family Connections is the our child protective services in this area.
Okay, thank you. I was all worried that we were missing
Yeah.
stuff.
And no. And I always say to myself as well, like, even if I don't have a lot of concern, like, I don't have the big picture. I don't know whether this family's already involved with Family Connections or not. But that's not for me to judge or for me to decide. My job is to call them, give them the information I have, and then they make that decision whether this information is worth investigating or not. So I always say, like, I just make that call. That's all I need to do. I don't have to have all the information. I don't need to know whether this needs to be investigated further or not. That's their job to figure that out. I just need to let them know what we're worried about today.
Great, thank you.
Yeah, no problem. No problem. Oh, yeah. My colleague Annette says there's a job posting up for a part-time nurse if anyone is interested. We're fun to work with.
Don't take them. I have a question about advertising. Just wondering what other communities, you know, that aren't in Aurelia, how the community would know about your services.
Yes, yeah. And I know we used to be better at advertising, but our best advertising is doing presentations like this, getting out to the hospitals, speaking with their emerge departments, talking to family physicians, talking to Family Connections offices in different communities, as well as connecting with police and just saying, we're here, we're open, we're seeing people, like, call us, and we're still taking care of people. Through all of COVID, we've never shut down our services. We're still taking care of people. So if you think we can be helpful, you think we need to be involved, just call us and we will figure it out. How we can best service these the clients that need our help. I think as far as people seeking us out directly themselves, like, we do have information on the Soldiers website. We used to say we're in the first page of the phone book under emergency services, but I don't think people have phone books anymore. But also if they were to Google sexual assault Aurelia, our information would come up if they were actively searching for help for themselves.
And do you think that transportation is a barrier for many people in the outside areas? I think some, like from what I see in the Emerge department, it's often, you know, police are more than happy to drive them there. Like our local OPP are great, but
Yeah.
those clients that really aren't sure they want OPP involved yet. So what do we do for them?
So we try to, usually we try to negotiate something with the referring agency. Like if you will taxi them to us, we will taxi them home. We try to assess their situation. If they have a friend or family member that they want as a support person anyways, is there somebody that way that's willing to provide them transportation? So we don't advertise that we offer transportation, but we will work with people to make sure that barrier is not the reason that they're not coming to see us.
Oh, that's great.
Does that make sense?
Absolutely. We're more than
Okay.
happy to provide a taxi. We do it frequently for different situations, and this sounds like a great reason to do it.
Yeah, and as long as they also feel safe and comfortable coming down in the taxi as well. But that's usually the last resort. Generally, we prefer if like an actual support person was bringing them down. But yeah, it depends on the different variables of the situation, but we won't let that be the factor that stops somebody from coming to see us.
Great, thank you.
Unfortunately, the other piece that goes along with that is that they don't want to, even if they have the transportation, they don't want to make that drive to come see us, because unfortunately from Parry Sound, that's like a full day excursion when you're driving at, what is it, like an hour and 15 minutes to an hour and 20 minutes to come down to us, be seen by us for 2 to 4 hours, and then have to make your way back again. That time itself can be a barrier for people to come see us, but we acknowledge that, and we still encourage people, just do this one time. It keeps your options open. And then we can go from there. If they're adamant that they don't want police involvement, that they will never want to do a kit, they will never want to involve police, generally West Parry Sound could provide them with the antibiotics for chlamydia and gonorrhea, pregnancy prevention medication. If the HIV PEP is a barrier, we have gotten that from us to like an accepting facility, either a pharmacy or hospital in Parry Sound, for them to be able to distribute that medication to the client. But that's on a case-by-case basis, and it's pretty rare. So, but just to know, like, we can almost always figure out a way for the client's needs to be met if they want our services. Any other questions? I do see we're at 1 o'clock. I think we provided our phone number in the presentation, but the phone number is also in the physician letter that I forwarded to Kathy, that Kathy will be forwarding to the attendees. And even if you guys want to print that out and post it up in your Emerge somewhere, so it's handy to see, then everyone will know how to get a hold of us, or that, you know, please do call us prior to just telling somebody to come down and see us. Yeah, that's pretty much our services and who we are and what we do.
I actually forwarded that on to Kara, our Emerge manager, so she can distribute to the team in Emerge. Not sure if anyone at the family health team wants it forwarded on, they can reach out to me.
Perfect.
Thank you.
All right.
I know our time's up. I have one really quick thing.
Yeah.
On this presentation, I'd really like to, we have a draft SOP for sexual assault in our Emerge department, but I was hoping from this presentation to just refine it. And would you be okay if I sent it to you for review to make sure I've got the finer points correct?
Absolutely. Yeah. Our team would love to, we can review that with our team. We can provide feedback or, yeah, absolutely. That would be great.
Thank you so much.
I think I'm just gonna throw my email up here. And then I know Kathy has my email as well. But then if you want to forward that to our team, we will work through that. There we go.
We also,
because
sorry,
that-
Simone, we also updated our pamphlets, and we can send you some to distribute in the emergency department or units, and also send you some posters that you can put in triage that just has our contact information and what services are available. Sometimes people take a screenshot of it while they're sitting there waiting to be triaged. We can send you that material as well.
That would be wonderful. Thank you so much. That was a great
Thank you.
presentation. Thank you.
Excellent. We're so glad that you guys came out and that you found the information useful. That's awesome. We like to get the word out as much as possible so that the people that need that care and support are getting it. So we appreciate your guys' time as well.
Thank
Okay,
you so much.
I'm not hearing any other questions, so thank you very much to the whole team at Aurelia.
no problem.
And just for our team here, our next rounds are January the 21st, and it's Dr. Carolyn Baer, who's going to present on acute coronary syndrome in women.
Thank you so much for having us, Kathy. We really appreciate the time.
Thank you so much, and I hope we can do this again in a year or so.
Absolutely. Keep our contact information. Hang on to it.
You'll be in my favorites.
Awesome. Excellent. Thank you
Thank
so
you.
much. You guys take care and stay warm.